Gossip.
This is Polyp Gossip, the place for physicians and patients to catch up on what's hot and what's not in CRS with NP or nasal polyp syndrome.
This podcast is developed by Sanofi Regeneron and also elaborated in close collaboration with EUFOREA. Welcome to episode 7 of Polyp Gossip, which is a unique initiative where we discuss the latest gossip of CRSwNP and what really matters for the medical community. And today we have a very specific topic, which is the concept of global airway disease and how much it applies to those suffering from chronic rhinosinusitis with nasal polyps. We are indeed confronted with the fact that care for patients suffering from chronic rhinosinusitis with nasal polyps remains often fragmented, and therefore multidisciplinarity of care needs to be embraced and needs to be discussed more in depth with those seeing patients suffering from severe uncontrolled CRSwNP. And today we feel very privileged by being by having two world leaders in the field of CRSwNP, one allergologist and one colleague ENT surgeon. And I would like to introduce my experts for this episode. The first one is Professor Dr. Anju Peters, allergologist from Chicago, and also leading the clinical research team in the Division of Allergy and Immunology at the Northwestern University of Chicago. And the second expert here is Professor Stella, an associate professor and otorhinolaryngologist at the Harvard Medical School of the Bremen and Women's Center in Boston, Harvard University. So welcome to both experts. So let's start the gossip now, because there's lots to say about upper and lower airway disease in the condition of CRSwNP. And my first question is, what evidence do we actually have that we should see CRSwNP as one disease entity rather than a pathology just limited to the upper airways? And maybe I address this question to Anju, you first.
Thank you very much, Peter. It's nice to be here with you, Stella. Typically, I don't like to gossip, but in this case, I do love it. When you say, the upper and lower airway, to me, it's very dear because we think of it as a unified airway. If you have disease in your sinuses and upper airways, then often these patients also have asthma, and especially with severe asthma where patients suffer a lot more. We know from studies done all over the world that patients with severe asthma have higher likelihood of having nasal polyps. For example, studies done in Europe have shown that more than 1/3 of patients with severe asthma have nasal polyps. They often have much worse disease, need oral steroids, sinus surgery, and still have exacerbations of asthma, often driven by their sinus disease.
Would you agree on that statement, Stella?
Yes, it's so important to think about the upper and lower airways as one continuum. And that's why it's so important to have these kinds of talks and gossips, because we need to work together. We need to share our research. We need to make sure our patients understand that it affects both the upper and lower airways. So critical.
So we are agreeing on the fact that both upper and lower airway inflammation often coexist in patients with severe uncontrolled CRSwNP. But what is actually driving the inflammation in these patients? Could you highlight or specify that one, Stella?
Wow, that's a complex question. Inflammation can result from many different, we're thinking more endotypes, which means understanding the types of cells and the pathways that create the inflammation in the nose and the sinuses and also affect the lungs too. And we're only beginning to use that language that, perhaps there's specific endotypes is what we call it. So there's now very advanced medicines that can target perhaps those cells and those pathways that help us all feel better and help our sinuses feel better and our lungs both at the same time because they're interconnected. Your thoughts, Anju, about this?
So Stella, I completely agree with you. I think this is so complex. We don't know exactly what causes nasal polyps, although we do think that the airway lining or epithelium, whether it be in the nose, lungs, may be faced by viruses, bacteria, allergens, pollutants, lead to what we call type 2 inflammation, which is an endotype, which to us is the underlying inflammation. And that seems to affect both the polyps as well as, so sinuses as well as the lungs, and maybe even other organs. But we are lucky that we now are starting to get treatment options. Even surgery for polyps helps improve lung symptoms and decreases medicines. But we now, I think, have better medicines that target that underlying inflammation that can treat both of those.
Yes, I'm very impressed that you mentioned surgery. So I appreciate that as a surgeon. But it does help. Yes, surgery can help the lower airways for asthma. And I think about the sinuses and sinus inflammation as sometimes like asthma of the sinuses too. So, yeah.
It's interesting also that you not only mentioned sinus surgery, but also better treatment options in the context of multidisciplinarity of care and why we're moving now into this more holistic approach of patients suffering from inflammation in upper or lower airways. Could you specify the new treatment options that have actually motivated physicians to consider CRSwNP as more a condition of the full respiratory tract?
I think that's really important for us to realize, as you mentioned, CRSwNP, or with nasal polyps, is a chronic disease and it's inflammatory at its underlying pathogenesis. Similarly, asthma is a long-term chronic disease and shares the similar inflammatory pathway. Other conditions do too, like atopic dermatitis, eosinophilic esophagitis. You know, for a long time for polyps, we start them on treatment with topical steroids. If they don't do well, we often recommend surgery. However, many of these people have disease recurrence, and you've published on it. And if they have disease recurrence, their options are surgery again, and they may get disease recurrence again, or these drugs, which we call biologics, that target the underlying inflammation. These medications have revolutionized how we treat our patients with especially severe asthma and nasal polyps. For economic reasons, I still think, Stella, and I think you'd agree, Peter, that most people should get at least one surgery for their nasal polyps, most patients. But if disease recurs, then we should think of these medications like biologics.
Yeah, I couldn't agree more, but if disease recurs, some of our colleagues would say like, okay, then you have not performed a proper surgery. So you, Stella, as a sinus surgeon, how do you look at this evolution where we now have more treatment options and where revision sinus surgery is now balanced against starting a biologic? How would you consider that?
Yes, so past 5 years, it's amazing. The revolution and the paradigm shifting ways that we're thinking about the disease and ways of treating the disease differently. And so surgery, as otolaryngologist and rhinologist, we take care of, as you mentioned, the holistic, the patient as a whole. We think about the upper and lower airways, but it's still an area that's an unmet need that we do need to do a better job. And when you think about comorbidities like asthma, almost about half of patients with chronic rhinosinusitis have asthma. So then if you think, you know, we can do surgery, we can help the asthma, but now there are these amazing other therapeutics, and that can target both the upper and lower airways. I think also it's about patient preference too. Some patients want to have surgery, some patients do not want to have surgery. And the fact that now we have all these other options, wonderful, right? That we can
Well, with all these different options and with also the context of the unified airway, the question that many patients may have is like, who is best placed to treat my CRSwNP? Is it the ENT surgeon? Is it the allergologist? Or is it even the pulmonologist? This is gossip, so you can talk whatever you think here. So, Anju, how do you feel now of being able to achieve control, for instance, if you as an allergologist see patients with uncontrolled disease after sinus surgery? How do you feel?
I think this is gossip at its best. I truly think, and I think we all agree, that we care for our patients. What we want to do is have the best treatment for our patients. So I do think this, especially in those complicated patients that have many comorbidities, they are best served by having a multidisciplinary approach. I work very closely with my ENT rhinology surgeon. We do a joint clinic together. I work closely with my pulmonologist because as we are figuring this out, we know many patients with nasal polyps, in fact, more than 50% have asthma. But some of those with severe asthma may have more severe lung disease that I might need to consult my pulmonologist if I see some bronchiectasis, which can be type 2. So I do think this is where a multidisciplinary approach works. And I do think what you brought up earlier, when I say at least one surgery, it should be a good surgery. And I even as an allergist,
good surgery as an allergologist?
I will tell you, I think it's a multidisciplinary approach. So any patient I see with nasal polyps, I don't want to miss something even if it's rare. What if it's a tumor or intracoinal polyp or malignancy? Every so often we see those. I don't want to miss it. So if I have a polyp patient, I definitely have them see an ENT, even if they don't want to have surgery at least once. And my surgery colleague will tell me if it's a good surgery or not. And I can tell a little bit by CT scan too.
Well, this is really wonderful because it seems like you're working in the perfect professional environment with close collaboration between allergologists, ENT, and pulmonologists. Is that the same in Boston?
It's very important. And I hope we really hopefully translate this model to other places globally. And I agree that every patient really deserves to, it's not just the imaging and all the other tests, but the really multidisciplinary care and the thoughtfulness for that individual patient and what their preferences are, what their comorbidities are, and also a good nasal endoscopy. That's why I find that sometimes these medications are prescribed and patients have never seen, for example, an otolaryngologist. And the opposite can be true too, is that asthma is really underdiagnosed. We see patients with chronic sinus problems and chronic sinus disease, and they have cough or they say they're wheezing. And we should also be thinking that we should educate our patients. You might also have asthma, and that's something that can be really treated and make you feel so much better. You're gonna be breathing amazingly better, and your quality of life will be better. So really important to have that team and thoughtful approach to each patient.
I think this approach is defendable and it's the best approach, but despite our opinion on this best approach of the unified airway problem, including severe CRSwNP, this is still not the case in the majority of secondary care centers. Could you speculate on the reasons why there is still not a multidisciplinary approach of those patients with severe CRSwNP in the majority of secondary care centers, at least not in Europe? Maybe it is in the US, but I have major doubts on that too. So what do you think are the obstacles from a logistical or financial or other perspective? What is your opinion here?
I think I would be speculating because I'm one of the lucky few who's had this since I finished training. I wonder if some of this is not financial. Some of it is also, logistical. You may not be in the same building, but if you have a really good relationship within, for example, as an allergist, when I talk to my allergy colleagues, I say, you don't have to be in the same room at the same time, but you should have a really good relationship where, for example, I can text my ENT colleagues, and I do on a regular basis, and they're very good about getting those patients in a timely manner. And sometimes we try and see them on the same day. But I suspect that access to care may not be there everywhere. It may be a lack of ENT surgeons who are qualified to do good sinus surgery, or it may be lack of allergists or lack of pulmonologists. Unfortunately, it may also be some financial and little turf wars where people may think, if I will not be doing enough sinus surgery if I get all these patients on biologics, or an allergist may think an ENT is going to do a lot more allergy shots. So unfortunately, that I think may play some role.
Would you agree on that statement, Stella?
Yes, and then the infrastructure, the way that we practice medicine needs to change. We need to have more conversations and talk to each other as physicians. And as we know, as healthcare becomes more and more complex, it's becoming more difficult for even patients to understand what we're talking about. And so that cross-talk between all of us, which is what we're doing here, really needs to happen everywhere. And if there can be a better way that we can share our documentation or talk to each other, have these multidisciplinary conferences. That really helps. But we do need to do a better job of a patient-centered approach rather than having each physician in their own offices. And patients are busy too, and they can't afford to go to one office and then make another appointment at another office. And we really try our best as, Anju, you have like a center where you and the otolaryngologist see the patient on the same day. That helps tremendously. So setting up those kinds of models, but does take a bit of planning.
It takes planning, it takes courage, and it takes also the guts to overcome all the challenges, logistical and other challenges.
Absolutely.
One other question that pops into my mind in the context of this multidisciplinarity of care, do we consider outcomes to be better if we work in these kind of multidisciplinary care centers than just in a monocenter approach or monospecialist approach? I think the answer is yes, of course, but from what perspective do you think it's better? Does it lead to higher patient satisfaction, or does it lead to better control, or do we already think about long-term control, sustained control, and think about remission? What is your opinion here?
I will tell you, that's something to think about. In asthma, there is some evidence to say that the multidisciplinary approach works well. And in asthma, when we think asthma, it's often allergist or pulmonologist with an ENT, sometimes GI. So I would think that it would be the same with CRS with nasal polyps. I definitely feel in my patients, it does, because if I'm thinking, does this person need antibiotic? I will say, no, I want to make sure you see the ENT colleague to get a good scope to see if there's pus draining and maybe get a culture. That's just a specific example. So over time, I do think outcomes are better. And if outcomes are better, that means probably less oral steroids, systemic steroids, probably less antibiotics, which then translates into better patient satisfaction also, I would think. But this is something to study.
Yeah, it's something to study. It will also be the subject of the next Polyp gossip. But anyhow, Stella, how would you see this kind of outcomes of care and how multidisciplinarity of care can improve outcomes?
Sure. I mean, that's really a goal that we should all strive for. And it's common sense, right? If you have doctors that are all thinking about the patient from different angles, and we are all collaborating and sharing ideas and thinking what's best for the patient, then offering the patient all the different options, and also including the patient in the conversation. That's really important. It makes sense. And centers of excellence, we know, do have better outcomes as well.
So we actually agree that this multidisciplinarity of care is very important, that it will lead to better outcomes, and that you also need good relationships, not only with your peers, but also with those seeing the problem from a different perspective, all taking into account underlying type 2 inflammation, right?
And I'd have to say, as an otolaryngologist, I've learned so much from my allergy, immunology, pulmonary colleagues that I can now better take care and recognize the symptoms that might be lower airway. And I hope I'm doing the same for I ask all of my allergy, immunology, pulmonary colleagues, please look in the nose or ask about smell loss. These are really important questions. So I learn from each other, and I hope we can only get better from that to take care of our patients better.
That's a nice and positive statement to end this show with. Maybe, Anju, you have a final statement?
I agree completely. I have learned so much from my ENT colleagues all over the world that I now see sinus disease with a different eye and realize the value that the whole multidisciplinary approach brings.
This is a very positive and hopeful message also for the future. We are the drivers of innovation in this field, I think, so we need to push harder even for more multidisciplinarity of care, and let's be confident that the future of these patients will be better than it has been before, right? Yeah. So that's a nice and positive statement at the end of this Polyp Gossip Show, episode 7 on multidisciplinarity of care. I thank my two hosts, the excellent contributors to this gossip show, Dr. Stella Lee and Professor also Anju Peters. And we invite you to join us also for the next episode of Polyp Gossip, which will also be about outcomes of care, long-term control, and the new concept of remission in CRSwNP, which is new, which is not so new in the field of oncology or rheumatoid arthritis, but in the field of CRSwNP. This is a new concept, this is a new ambition of care, and we welcome you to join us for episode 8 soon.
Polyp Gossip. This was Polyp Gossip, sponsored by Sanofi Regeneron and developed in close collaboration with EUFOREA.